artery anomalies, which we find very often. Yet another one is TOF associated with atrial septal defect. We call it pentology. Yet another one is TOF with presence of major aortopulmonary collaterals. Usually we see it when the child is older or in adult TOFs. And another common variant is TOF with common atrioventricular septal defect, that is TOF with AVCD. In TOF with pulmonary atresia, the pulmonary trunk is hypoplastic and there may be discontinuation of the branch pulmonary arteries. The aortic arch is right-sided in many of these cases. And the pulmonary blood flow in TOF with pulmonary atresia depends on totally on the presence of MAPCAS and persistent ductus arteriosus. That is TOF with pulmonary atresia. Regarding TOF with absent pulmonary valve, as I said previously, it is associated with massively enlarged pulmonary arteries and a malalignment type of VSD. The pulmonary valve actually may not be absent. It may be rudimentary. And even the pulmonary annulus may have varying degrees of hypoplasia. These children, because of the massively enlarged pulmonary arteries, which may press upon the bronchus, may present with dyspnea. And they are usually nursed when they are infants in the prone position. Even when they are brought to the theater, they are brought in the prone position. In these cases, the malalignment of the outlet septum is what contributes to the right ventricular outflow tract narrowing. And these patients with absent pulmonary valve have severe pulmonary regurgitation, which also results in dilatation of the right ventricular outflow tract. These neonates, as I said, present with severe respiratory distress due to compression of the trachea or bronchi by the aneurysmal pulmonary arteries. Regarding coronary artery anomalies, anomalies may be in the form of abnormal branching patterns of origin or of branching. If an anomalous coronary artery crosses the right ventricular outflow tract, surgical repair may be complicated because coronary artery injury may occur. The most common anomaly involves origin of the left anterior descending artery from the right coronary artery. Other coronary anomalies may also be present, such as dual left anterior descending, single right coronary artery, single left coronary artery, and coronary pulmonary artery fistula. Now, a bit about tetralogy with complete AVCD. TOF with complete atrioventricular septal defect is a relatively rare variant. And the degree of cyanosis depends upon the degree of malalignment of infundibular septum and consequently the degree of right ventricular outflow tract obstruction. When TOF is associated with complete atrioventricular septal defect, the atrioventricular septal defect is usually of the Rastelli type C. That is where the superior bridging leaflet is free floating. Now about tetralogy with double outlet right ventricle. Some controversy exists regarding whether double outlet right ventricle associated with tetralogy should be considered as an extreme variant of tetralogy or whether it should be grouped under double outlet right ventricle. Opinion regarding the definition of double outlet right ventricle varies among the authors. Usually, the anomaly is considered double outlet right ventricle when more than 50% of aorta or 90% of aorta arises from the right ventricle. It is the double outlet right ventricle is also defined as absence of fibrous continuity between aortic and mitral valves. Now, we will divide the topic into mainly two parts. One is echocardiography before cardiopulmonary bypass and transesophageal echocardiography before cardiopulmonary bypass and transesophageal echocardiography after cardiopulmonary bypass. Almost always, the diagnosis of tetralogy is established on preoperative transthoracic echo. So we get a diagnosed patient into the operation theatre. What is the goal of intraoperative transesophageal echo before establishment of cardiopulmonary bypass? Mainly, it is to detect deviations from the diagnosis. 1. 2. To detect any associated anomalies which have not been detected by transthoracic echo. And 3. To perform a comprehensive hemodynamic assessment. These are the three aims of transesophageal echo before cardiopulmonary bypass. What should we focus on in the pre-bypass period? We should focus on the location of the VSD, its size, and whether there is any extension of the VSD. We should look for any additional VSDs. Next, we should assess the degree of right ventricular hypertrophy. And thirdly, we should look at the right ventricular outflow tract obstruction. What should we assess regarding the obstruction? The level of obstruction, the degree of RVOT narrowing. We should measure the Doppler gradient across the infundibular obstruction, the size of the pulmonary artery annulus, and whether any valvular pulmonary stenosis is present or is it only infundibular obstruction. And we should look at the pulmonary valve morphology. Is it normal? Is it bicuspid? One should always also look for the presence of any supravalvular tethering. Now, what are the other things that we should focus on in the pre-bypass transesophageal echo? The degree of iotic override. As I said previously, whether there is any double outlet right ventricle. Look at the pulmonary trunk size, presence of any branch pulmonary artery narrowing or stenosis, which is not very easy to do. Presence of confluent stenosis, which we can easily see. Look at the size of tricuspid valve, the chambers, the right ventricle, the left ventricle, size of the LA. Size of the LA is very important. And look at the aorta size. See whether there is any evidence of coronary artery crossing the right ventricular outflow tract. May or may not be seen in echo. You can see it visually on the table. A detection of any major aortopulmonary collaterals can be seen. Whether there is absent pulmonary valve, whether there is PDA. Now this PDA is better seen in the transthoracic echo. Still many times we do see on the transesophageal echo. Whether there is any aortic regurgitation, which is not at all uncommon. Now the views. What are the views for tetralogy of Fallow? The first view is the four-chamber view. There you can look for the tricuspid valve size. Look at the RV, is it hypertrophied? Look at the LV, see whether it is pentology, is there ASD? You may also see the VSD, if any muscular VSD or inlet extension of VSD is seen, then you will see it in the four-chamber view. Next is the mid-esophageal aortic valve short axis view. In this short axis view, you can look at the LA. Is the LA small or is it normally sized? You may also see any aortic regurgitation, and if you are lucky, you may see any coronary artery anomalies if it is there. Now, next view is the mid-esophageal RV inflow outflow view, which is a very, very important view for looking at tetralogy of Fallow. In this view, you can see the VSD location and size. A typical perimembranous Vsd is seen in this view. Look at the direction of flow and look at the degree of infundibular obstruction, RV hypertrophy, right ventricular outflow tract size, the pulmonary valve size and morphology, and the proximal pulmonary artery size. You cannot measure any gradient in this view. Doppler cannot be measured. RV outflow tract gradient cannot be measured in this view, but here you can see all these things. And definitely use a color flow Doppler if there is at the obstruction site, you can see the obstruction. Next is the mid-esophageal long axis view. This view is what we use for assessing the degree of aortic override. Here also you can see the location of VSD and the direction of flow across VSD, and color flow Doppler, you can see the aortic regurgitation if there is any. Now we come to the other views. Upper esophageal aortic arch short axis view. Upper esophageal aortic arch short axis view. This is a view which you can use for measuring the Doppler gradient across RV outflow tract. So this is one of the views where you can measure the Doppler gradient across the RVOT. We'll come to this view later in the TE. Now in this view, upper esophageal aortic arch short axis view, you may also look for presence of major aortopulmonary collaterals. Use color flow Doppler and you may see if it is present. And this is also the view for the persistent ductus arteriosus. As I said previously, PDA is better seen in the transthoracic echo. So this is the view to be used for looking for MAPCAS and PDA, upper esophageal aortic arch short axis view. The mid-esophageal aortic short axis view is a very, very popular view for measuring the Doppler gradient across RVOT. If we use various views to measure the Doppler gradient across the RVOT before and after repair in case of TOF, this view gives the highest gradient and it usually correlates with the epicardial echo gradient. So the highest gradients are usually got from mid-esophageal ascending aortic short axis view and the epicardial echo view. In this mid-esophageal ascending aorta short axis view, you can also see the PSIs and the right pulmonary artery stenosis. The left pulmonary artery is usually not visible in this view because it is obstructed by the, its view is obstructed by the bronchus. Now, other views to be used in for looking in TOF are the transgastric mid-papillary view. There you can look for muscular VSDs in the lower part of the septum. Yet another view is the transgastric RV outflow view. I'll show you this view later, and here you can measure the right ventricular outflow tract gradient. So here they are, the 8 views that are used for tetralogy of Fallow. The VSD, we'll talk a bit about the VSD. The VSD is usually situated in the membranous septum, as we said previously, and it may have extension to either the inlet region of the right ventricle or to the infundibular area. If there is inlet extension, then you may see it in the 4-chamber view. Now, in which views will you see the perimembranous VSD? It may be seen in the 5-chamber view, RV inflow outflow view, and the mid-esophageal aortic valve long axis view. The usual views for looking at a perimembranous VSD. So, as I said previously, the inlet VSD, if there is an inlet extension of the perimembranous VSD, we can see it in the 4-chamber view. However, here we have to be careful because right on in the mid-esophageal 4-chamber view, we may not see it. So we have to slightly retroflex the probe to look at it because it may appear only during retroflexion. I have seen one case where in the post-op period, after the perimembranous VSD has been closed, in the post-op, in the post-CPB period, when we did an echo in the 4-chamber view, there was no residual VSD. But on slide retroflexion, we saw a fairly good inlet VSD. So always, be it in the pre-bypass period or post-bypass period, when you are looking for a VSD in the 4-chamber view, in addition to looking in the 4-chamber view, always retroflex and see whether the VSD is appearing. Now, outlet VSD, also called supracrystal VSD, is visualized in the RV inflow outflow view only, if it is there. As the VSD remains unrestricted, the direction of flow is determined by the degree of right ventricular outflow tract obstruction and the systemic vascular resistance. So there it is. In tetralogy of Fallow, the VSD is usually unrestricted. And what determines the direction of flow? It is determined by the degree of right ventricular outflow tract obstruction and the systemic vascular resistance. To delineate the direction of flow, one should use both color Doppler as well as spectral Doppler guides. Now, this is a figure, not a video. Here we can see the color comparison in the mid-esophageal 5-chamber view, which reveals a large perimembranous Vsd, denoted here by the white arrow. One can also see aortic override. This is the interventricular septum, and see the aorta is overriding the interventricular septum. So both blood from RV and LV is going into aorta. The RV is also hypertrophied, which you can better see in the next video. Now, in tetralogy, assessment of the tricuspid valve, the right ventricle, the LA, LV, and aorta are important in the pre-op as well as the post-op period. Why? Small tricuspid valve and small RV may be relative contraindications for performing an intracardiac repair. I'll repeat that. Small tricuspid valve and small RV may be relative contraindications for performing the intracardiac repair. So in the pre-bypass period, one has to assess the size of tricuspid valve and RV, and if they are small, we have to inform this to the surgeon. Now, in tetralogy, the left side, that is the LA and the LV, are subjected to less volume load because of the reduced pulmonary blood flow. There is less pulmonary blood flow coming into the LA. An additional or residual Vsd after intracardiac repair may be associated with increased PA pressure in the presence of small left-sided chambers. So, in the post-CPB period, even if you find a small residual Vsd, whether to repair it or not depends not only on the size of the residual Vsd, it also depends upon the size of the left-sided chambers. So you measure the size of the left-sided chambers both in the pre-bypass period as well as in the post-bypass period. This is a video. Now you can see here the RVs. Normally RV goes only up to 2/3 of the interventricular septum. Here it goes down. So the RV is hypertrophied. You can see the override, the Vsd. Aortic override, Vsd, the RV hypertrophy. Tricuspid valve size is fairly okay here. You can see the tricuspid valve, the mitral valve size. Now, regarding the Vsd, you can see in this figure that there is a large perimembranous Vsd in the RV inflow outflow view. So RV inflow outflow view is the view that we use to look at the most common type of Vsd in TOF, that is the perimembranous Vsd. You can also measure the size of the Vsd. Before you put the, you can see the size of the Vsd, measure the size of the Vsd. Now, as I said previously, sometimes accessory tricuspid valve tissue may partially close the Vsd, making it restrictive and causing the RV pressure to rise very high above the systemic pressure. Now, one should also look for additional Vsds in the muscular septum. This can be inspected in multiple views. In whichever views you can see the septum, you have to look for additional Vsds. This may be the 4-chamber view, the mid-esophageal 4-chamber view, the mid-esophageal long axis view, and the transgastric mid-papillary view. So in all these views, you look for the presence of additional Vsd. However, you may not see these additional muscular Vsds in the pre-CPB period. Because, why? Because the flow through between the ventricles takes place predominantly through the huge unrestricted Vsd, the perimembranous Vsd, and which is the path of least resistance. So in the pre-bypass period, you may not see these Vsds at all, which means in the post-CPB period, one has to look again for the presence of muscular Vsds, the flow through which may open up only in the post-bypass period after the huge unrestricted perimembranous Vsd has been closed. This is a figure Mid-esophageal long axis view, you can see the VSD here, the biotic VSD shown by the arrow. You can also see the iotic override, the mid-esophageal long axis view. That's a video of it. Look at this. You can see the VSD. You can see the override. Now let's speak about the right ventricular outflow tract obstruction. This may occur at different levels. It could be at the level of infundibulum, the pulmonary valve annulus, the pulmonary valve cusps, or it may be even above the pulmonary valve. Why does this infundibular obstruction occur? It occurs due to malposition of the infundibular septum. Now, how can the patient is usually a child. The pulmonary valve annulus should be compared with the expected size of the annulus. So you can use the Z score for this. The pulmonary valve may be thickened, or it may be tethered, or it may be both thickened and tethered. Sometimes the pulmonary valve may even be bicuspid. In 10 to 15% of the cases, the pulmonary valve is dysplastic, resulting in severe pulmonary regurgitation. Now, this RV mid-esophageal RV inflow outflow view is the view that we commonly look at to look for the RV outflow tract obstruction. Here you can see the level of obstruction. Here you can see that the infundibular level there is obstruction. Here there is the pulmonary valve. So you look at this view both with color and without color, and as I told before, we cannot measure the Doppler gradients using this view. So this is the most popular view for looking at tetralogy of Fallow, and here also you can see the perimembranous Vsd. So here you can see perimembranous Vsd. You can see the place of Rvot obstruction, the degree of Rvot obstruction. You can look at the pulmonary valve, the pulmonary artery. If you put color, you can even see whether there is iotic regurgitation. The same picture, figure, RV inflow outflow view. It shows a large perimembranous VSD. It shows, here it is, this thick arrow here. It shows infundibular narrowing, the thin arrow here, and it shows a hypoplastic pulmonary valve, this arrowhead here. Now, the gradient across the right ventricular outflow tract needs to be measured using spectral Doppler. We cannot measure it in the RV inflow outflow view. So which are the views to be used? You can use the upper esophageal aortic arch short axis view, the mid-esophageal ascending aorta short axis view. You can also use the transgastric RV outflow view. These pictures will be shown later. So these are the views: upper esophageal aortic arch short axis view, mid-esophageal ascending aorta short axis view, which is the best view where you get the higher gradient, and transgastric RV outflow view. The gradient may vary in each of these views because of limitations in aligning the Doppler beam parallel to the flow. So one should be aware of this, and one should not confine oneself to just one view. One has to measure it in 5 views, including the epicardial echo. Now, if optimum pressure gradients are not obtained in these views, epicardial echo may be used as a complementary method. In our institute, we always use epicardial echo and the remaining various views of transesophageal echo. That is why I said that the maximum gradients are usually seen in the mid-esophageal ascending aorta short axis view and the epicardial echo views. Now, RV outflow tract obstruction is considered mild, moderate, or severe when peak pressure gradient is less than 36 millimeter mercury, 36 to 64 millimeter mercury, and more than 64 millimeter mercury respectively. So peak pressure gradient more than 64 millimeter mercury is considered severe RV outflow tract obstruction. Something between 36 and 64 is considered as moderate RV outflow tract obstruction. Now here are the 4 views. Now, this slide is very, very important. One should keep this slide in the mind. These are the views for measuring pressure gradient across the RVOT. And any anesthetist who is doing tetralogy should measure the gradient in, or at least attempt to measure the gradients in these 4 transesophageal echo views before and after repair, that is before CPB and after CPB. The first one, that is A, the first picture here is the mid-esophageal ascending aorta short axis view. Mid-esophageal ascending aorta short axis view. Here you can see the gradient. Mid-esophageal ascending aorta short axis view. Now, yet another view here, B, is the transgastric RV outflow view. So this is a transgastric view. This is the RV. This is the RV outflow tract, and you can see the pressure gradient. So transgastric RV outflow view. Now this one, C, is the upper esophageal aortic arch short axis view. Upper esophageal aortic arch short axis view. Now these gradients are measured. This picture is of different patients. It's not of the same patient. And D is the epicardial RV outflow tract view. Here also you can see the measure gradient. Usually what I have seen is the gradient in the epicardial echo and the gradient in the mid-esophageal ascending aorta short axis view are usually close. They are usually almost the same. Now, sometimes you may see pulmonary artery anomalies, including hypoplastic trunk and branch pulmonary arteries or confluent stenosis. Hypoplastic trunk and confluent stenosis are easily seen. To look at branch pulmonary artery stenosis, a little difficult. On the right side, you may see it. Now, stenosis of more than 50% of the diameter of the branch pulmonary arteries is considered significant and requires widening. So, the surgeon has to widen if the branch pulmonary artery is stenosed by more than 50%. The main pulmonary artery and the right pulmonary artery are well visualized in the mid-esophageal ascending aorta short axis view. The main pulmonary artery is also seen in the RV inflow outflow view. So it is not difficult to assess it is very easy to assess the size of the main pulmonary artery and the right pulmonary artery. In case of tetralogy with absent pulmonary valve, the pulmonary arteries are all dilated. The main pulmonary artery, the right pulmonary artery, and the left pulmonary artery, they are all dilated, and the pulmonary regurgitation is usually severe. And as I said, these dilated pulmonary arteries, they press many times, they press upon the bronchus, causing severe dyspnea to the for the infant. Now, in the presence of pulmonary annular narrowing and a large VSD, the gradient exists between the right ventricle and the pulmonary artery, and the pressures in both ventricles are equal. I'll repeat that. In the presence of pulmonary annular narrowing and a large VSD, the pressures in both ventricles may be equal. Now, this is a figure A. It is a zoomed view of the pulmonary valve at upper esophageal aortic arch level, and it shows a thickened pulmonary valve. The pulmonary valve is thickened. The figure B, it shows a supravalvular narrowing. You can see the white arrow. It's a supravalvular narrowing. It's seen in the main pulmonary artery. Supravalvular narrowing in the main pulmonary artery. Upper esophageal aortic arch level. Now this is a transgastric picture. Transgastric RV outflow view. This is a view I mentioned previously where you can measure the gradient across RVOT. So here you can see the transgastric outflow view. Transgastric outflow view. This is RV, this is LV. The transgastric outflow view reveals at the level of infundibulum. You can see the obstruction in the color Doppler, and the pressure gradient. Pressure gradient is 51 at this obstruction. So this is one view which you are using, transgastric RV outflow view. A bit about epicardial echo. Now, epicardial echo is very important. It is not instead of transesophageal echo. It is complementary to transesophageal echo. So one should always encourage the surgeon to do epicardial echo as well, because it is complementary to the gradient measured across right ventricular outflow tract. One should use both transesophageal echo and epicardial echo, and there is no need for any needle puncture. Now, in epicardial, this view shows epicardial RV outflow tract view. It shows infundibular narrowing. See, this is the RV. At the top, this is the outflow. Here you can see the infundibulum, and you can see that the infundibulum is narrowed. This white arrow shows infundibular narrowing. And this is the RV outflow. This is the pulmonary artery. And you can see the hypoplastic pulmonary valve. This arrowhead shows the hypoplastic pulmonary valve. The epicardial. One should be familiar with the pictures of epicardial echo. All the 7 to 8 views are there. One should be familiar with it. So it is a surgeon who will put the probe on the heart, and we have to look at the pictures and interpret and also make adjustments for the pictures and see color Doppler, gradient, etc. This is the same thing. So you can see here on the top here, the RV outflow tract obstruction. Here you can see the pulmonary valve. So this is the one has to see the RV outflow tract. Here it is clearly seen, RV outflow tract obstruction. As this is upper esophagus. As I said previously, one should look for the MAPCAS, major aortopulmonary collaterals, especially in a bigger child or in an adult toss. So this is how it appears. You can see the MAPCAS. This is you can see all these things. You can see this kind of reticulated appearance, and when you're using color flow Doppler, you can see the flow as well. This is how the MAPCAS look like in a transesophageal echo picture. A bit about surgery before we go to the post-bypass period. Now, BT shunt, blalotoxic shunt, may be required in infants below the age of 3 months with severe systemic desaturation, pulmonary arterial hypoplasia, or large coronary arteries crossing over the RV outflow tract. Nowadays, we rarely see this BT shunt being done because nowadays primary intracardiac repair is safely performed above the age of 3 months also. So nowadays, we very rarely see BT shunt. However, in rare instances, it may be required in children below the age of 3 months with severe systemic desaturation or large coronary arteries crossing RVOT or pulmonary arterial hypoplasia. In intracardiac repair, that is primary ICR, in today's times, is done by the age of 3 months or even before. Now, what is done in intracardiac repair? A wide spectrum of surgical corrections are done. One is the resection of obstructing infundibular muscles, which is almost always done. The obstructing infundibular muscles are resected. Next comes a patch, a right ventricular outflow tract patch or a transannular patch. Now, this is important, whether it is a transannular patch or a RVOT outflow patch. If it is a RVOT outflow patch, the post-op period is smooth. If it is a transannular patch, in the post-op period, because of the pulmonary regurgitation, the patient may have right ventricular failure. So, even regarding our weaning and extubation, if it is a right ventricular outflow tract patch only, then we know that on the same day itself, child will be weaned and extubated. If it is a transannular patch, it may or may not be possible to wean and extubate on the same day. Now, surgeons, when you're using a transannular patch, may do a monocusp reconstruction of the right ventricular outflow tract. It depends upon the center. In our center, they always do it using a bit of pericardium. How long it stays there, we do not know. But definitely it helps to tide over the immediate post-op period. Now, our cardiologists say that after 1 or 2 years, they many times do not see this monocusp valve at all. That means it has disappeared. However, for the immediate perioperative period, this monocusp reconstruction using a bit of pericardium is very useful. Pulmonary valvotomy may be done. Pulmonary artery reconstruction may be done. If there are MAP casts, then it may be ligated. If there are additional VSDs, then they are closed. Sometimes, rarely, homograph placement may be required in redo surgeries or in those with severe hypoplasia of the pulmonary artery. So rarely homograph placement is done. Now, for the route of surgery, surgery can be performed either via right atrium can be performed via RA, PA or RV approach. So these are the approaches to repair of the VSD and TOF repair. Now we come to transesophageal echo after cardiopulmonary bypass. Now, RV outflow tract pressure gradient exceeding 40 millimeter mercury suggests residual RV outflow tract obstruction, necessitating the re-establishment of cardiopulmonary bypass for further correction. So, pressure gradient across the RVOT exceeding 40 millimeter mercury suggests a residual RV outflow tract obstruction, and you may have to re-establish CPB. Now, why should this occur? This pressure gradient after repair. Inadequate infundibular resection will result in high pressure gradient across RVOT. But one should also be aware, the anesthetist should be aware that inotropic support increases the contractility of infundibular muscles and causes tachycardia, which may be responsible for reversible increase in the infundibular gradients. So if you have a doubt, you can stop the inotropic support, or you need not start the inotropic support in the first place before you measure the RVOT pressure gradient. So it is a certain group of anesthetists, they do not start the inotropic support before they measure the post repair RVOT pressure gradient. Some of the anesthetists, they start the support, but if there is any doubt, if the pressure gradient is high, then they may stop the support, wait, and then again measure the RVOT pressure gradient. So the RVOT pressure gradient may also be affected by the inotropic support which the anesthetist start. One should be aware of it. We come back to the same slide again. The views for measuring pressure gradient across the RVOT. The mid-esophageal ascending aorta short axis view, the most popular view for measuring the gradient across RVOT. This is the transgastric RV outflow view. This is the upper esophageal aortic arch short axis view, and this is the epicardial view. These views are commonly used for measuring the gradient across the RVOT. Now, sometimes the right ventricular outflow tract widening using outflow patch may be inadequate to provide sufficient room for the right ventricle to empty into the pulmonary circulation. And in such cases, as we said before, a transannular patch may be warranted. What is a transannular patch? It is a patch which grows across the pulmonary valve. Now, pulmonary obstruction may also occur due to persistent supravalvular tethering, stenosis at the pulmonary artery confluence, or stenosis at the origin of the pulmonary branch arteries. So, if there is a high gradient, one should also be aware that obstruction at these areas may be cause of the high gradient. Now, placement of the transannular patch, which is quite commonly placed, it causes pulmonary regurgitation. Always it causes some degree of pulmonary regurgitation. Peak pulmonary velocity exceeding 1.5 meters per second and a reversal of flow in the branch pulmonary arteries indicates that the pulmonary regurgitation is very severe. If the pulmonary regurgitation is severe, one can really expect RV to go into failure in the post-op period. The right pulmonary artery can be interrogated in ascending aorta short axis view, which we have seen previously, wherein the Doppler beam can be placed parallel to the flow. So RPA can be interrogated. To interrogate the left pulmonary artery is very, very difficult. Almost, it's very difficult. So RPA can be interrogated in the ascending aorta short axis view, wherein the Doppler beam can be placed parallel to the flow. As I said previously, in some centers, monocusp reconstruction of the Rvot is done because it is beneficial in reducing the grade of pulmonary regurgitation. It is done with a bit of pericardium of the same patient. The pulmonary regurgitation should always be evaluated after a transannular patch has been done. Now, other factors that you have to consider in the post-bypass period. Excessive resection of the right ventricular muscles may lead to RV systolic dysfunction. So, the surgeon cannot excessively resect the RV muscles also because it can lead to RV systolic dysfunction. When the right ventricle is very hypertrophic, which we have assessed in the pre-CPB period also, when the right ventricle is very hypertrophic, diastolic dysfunction can occur in the post-op period. So after TOF repair, systolic dysfunction can occur if of the RV can occur because if RV muscles are excessively resected. In the post-op period, diastolic dysfunction can also occur because of the RV hypertrophy which the patient has. Now, RV diastolic dysfunction should be suspected in a patient with preoperative severe hypertrophy of the RV free wall, in whom persistent forward flow is visualized through the pulmonary valve during late diastole. So, in the post-op period, one can expect RV diastolic dysfunction, especially when the RV is very hypertrophic and you have noticed RV hypertrophy in the RV free wall. At the infundibular level, they will do some resection. But RV free wall, if it is highly hypertrophic, one should be aware that RV diastolic dysfunction can occur in the post-bypass period. And when one can look for persistent forward flow through the pulmonary valve during late diastole. If there is, in this case, diastolic dysfunction of RV, you may see forward flow through the pulmonary valve during late diastole. Now, in the post-bypass period, one should look at the VSD patch to see whether there is any residual shunt. Now, to detect any additional VSD, TEE is more sensitive. TEE is more sensitive in detecting additional VSD than the step up in oxygen saturation at the pulmonary artery. So one need not go and take samples and send for blood gases, etc., because TEE is more sensitive in detecting additional VSDs than the step up in oxygen saturation in the pulmonary artery. Now, as I said previously, one should look for additional muscular VSDs in the post-bypass period. After surgical closure of a large perimembranous Vsd, additional muscular VSDs may become apparent in the post-cardiopulmonary bypass period. And it is just a clue that muscular VSDs are often detected in the area adjacent to the moderator band. The muscular septum should be inspected in mid-esophageal 4-chamber view and transgastric mid-papillary view. You may see it in the other views wherever you see the septum, but in these views, you should certainly look for muscular VSDs. Mid-esophageal 4-chamber view and transgastric mid-papillary view. Now, it is a fact that apical VSDs may not be easily detected with transesophageal echo. We do see it sometimes, but it may not be easily detected. Now, in the post-bypass period, supposing you find a residual VSD, then what to do? If the VSD is less than 2 millimeter in size, it may be left alone. VSD is more than 5 millimeter size should be addressed surgically. When the VSD size ranges between 2 millimeter and 5 millimeter, then you have to measure QPQS, pulmonary to systemic blood flow ratio. And if this is more than 1.5, you may use this as a criteria to close the ventricular septal defect. It is a good habit to measure QPQS in all left to right shunts, pre and post CPV. Now, after cardiopulmonary bypass, supposing RV pressures are remaining high, many surgeons, they create a fenestration in the atrial septum. So, a fenestration in the atrial septum may be created as a pop-off mechanism for elevated RV pressures after cardiopulmonary bypass. Now, what can we do to help? Color flow Doppler and spectral Doppler across the fenestration provides clue regarding the left atrial pressure. As I said previously, sometimes one uses a some surgeons, sometimes in certain cases, even in tetralogy, a homograft is required. A valve conduit or a homograft may be placed between the right ventricle and the pulmonary arteries. Now, one has to visualize the homograft using transesophageal echo, but in the standard views, you usually do not see it. So, you may have to use non-standard views. Visualization of the homograft is performed in the off-axis views, which means non-standard views, extending from the right inflow outflow view. So use the right inflow outflow view as a base, and then you adjust and adjust and adjust till you see the homograph. It is not at all difficult. It is very easy. Now, why should you visualize it? Because sternal closure may result in compression of the conduit, resulting in high Doppler gradient. If the conduit is placed in the anterior portion of the mediastinum. It is not unusual. This is not unusual. So, if a homograft is placed in the anterior portion of the mediastinum, it is the duty of the anesthetist to measure the gradient across the conduit. And if it is high, one has to inform the surgeon. Otherwise, when the sternum is closed, there will be a high gradient. If the gradient is high, if you inform the surgeon in time, they will try to adjust and position the homograft in such a way that it is not compressed by the sternum. This is a figure. It shows one is looking at the VSD to see whether the patch is intact. Color flow Doppler across the VSD patch. This arrow shows a VSD patch. This white arrow shows the VSD patch. This is a typical 4-chamber view. So one should put color and see whether there is any flow across the VSD, whether the patch is intact. So this picture shows that there is no residual VSD and the patch is intact. The patch is seen as a white color. You can see the patch. This is a patch. This is the same picture. It's a video of the same picture. You can see that the patch is intact. So this is one of our functions in the post-bypass period. Look at the patch, see whether there is whether it is intact, see whether any stitch has given way and whether there is any flow across the interventricular septum, especially at the edges of the patch. Another duty of ours in the post-bypass period is to look for any extra VSDs, muscular VSD, which we could not see in the pre-bypass period because the major flow was occurring across the perimembranous Vsd, making it impossible to detect any muscular VSDs. So here in the post-bypass period, you can see this is a figure. mid-muscular, this is a mid-muscular additional VSD shown in this white arrow. It is seen after closure of a large perimembranous VSD. So a large perimembranous VSD was closed, and when we were looking for any additional muscular VSDs, this is what we found, a mid-muscular VSD, additional VSD. So one needs to look for it using color Doppler. As I said previously, the most popular views for looking at additional muscular VSDs is the 4-chamber view and the transgastric mid-papillary view. So here is the 4-chamber view. You can see the muscular VSD. Now this, you can, as you see, it is in the mid portion of the septum. Apical VSDs may be seen. We have seen it, but it's not very, you may also miss it. As I said previously, in many centers, monocusp reconstruction of the RV outflow tract is done when the surgeon uses a transannular patch. Now here you can see the arrow, that is a small piece of pericardium. That is what they have done, a monocusp reconstruction of the RVOT. And the function of this monocusp valve is to tide over the immediate post-operative period, where the post-op period will be smooth and there will be no right ventricular failure, and we can easily wean and extubate the patient. The patient slowly gets used to the transannular patch. If you don't keep this valve, in the era where we never used a monocusp valve, we have found a lot of difficulty in weaning off the patients, especially when there is a large transannular patch. So long ago, we started using this monocusp valve, and we found that post-operative period was smooth. This is a video of the same figure that I showed previously. Here you can see the monocusp valve. This monocusp valve is very easily seen. One, it is dark white in color. Another thing, it pops up and down, dancing all the time. So monocusp valve is here, seen. Thank you.
Dr. Rupa Shreedhar, that was an excellent presentation of Tetralogy of Fallot, taking into account all the aspects of the disease when we subject these patients for surgical procedure. I would like to acknowledge that you have covered extensively and very, very clearly with adequate illustrations and video pictures. I'm really thankful to you. And if anybody wants to ask questions and comments, we can allow to another 10 minutes. We are a little bit late, but I don't mind it because it's a very important subject, and the expert was dealing with it, and that's why I didn't feel like interrupting it. So it was very well done. Anybody would like to comment or add any points or ask questions? To start the ball game, I'll myself ask one question. When we measure the gradient across the RVOT after bypass, is there any difference when you use the needle technique? If I measure the RV pressure and PA pressure and determine the gradient, vis-a-vis the gradient obtained by the echocardiography, will it be similar, or which one is more accurate?
So previously, before we became very familiar with transesophageal echo, even during the early periods of transesophageal echo, we always used to measure the needle gradient.
Yes.
Always. But later, when we became thorough with the transesophageal echo, then also we used to measure the needle gradient. But once we started using both transesophageal echo and the epicardial echo, in all cases, then we stopped measuring the needle gradient, because our surgeons also, it is a surgeon who actually puts in the needle. So when they are also doing the epicardial echo, they feel that they are also doing something. So then they stopped using the needle gradient. So now we are not measuring the needle gradient at all. So we do it using the transesophageal echo plus epicardial echo. And as I said, the highest gradients are seen in the mid-esophageal ascending aorta short axis view and the epicardial echo view. And these gradients almost always correlate. And the highest gradients are seen in these views. So
I agree with that. I agree with, but my question is the needle gradient not as accurate as echo. That's why you abandoned that, or it's because of the convenience that the surgeon did not want to put the needle in the both the RV and PA. You abandoned.
Um, I think it is because this is a non-invasive technique, and both anesthetists and surgeons started believing in this technique. That's why we
Yeah.
abandoned. Whether the gradients will be exactly the same gradient, I really do not know.
And
Sir,
only
can I
thing,
comment?
yeah. Only thing is the gradient measured by the needle are in two different cardiac cycles, whereas the gradient measured in the echo is the same cardiac cycle.
Okay.
So that matters in cath lab, but I don't think it matters in the operative period.
Okay.
Keshav, yes, come on.
Madam, the presentation was as colorful as the peacock feather, which is last projected. Very nice, and thank you, madam, for that wonderful presentation.
Thank you.
This regarding this gradient, the most common thing when the surgeon uses the needle, the moment they find that the RV pressure is at least 60% or 70% of the systemic pressure, they immediately drop the needle aside and start going ahead with their future steps. They say everything will be all right. But for that, in some cases, measured both transgastric gradient across the pulmonary this patch, and direct, as said, sir said, it is two different cardiac cycle. But if the pressures are systemic pressures are maintained, the minus RV pressure minus the PA pressure, we get the almost some 3 to 5 difference gradient across this needle pressure measurement also.
Okay. Thank you.
What happens is most commonly we put the needle, and if the needle pressure shows 70% or even 60% of systemic pressure, then we are happy that the Rvot is opened up and the patient is going to do okay. They don't even measure the PA pressure. But when we have found that the RV pressure is almost close to systemic or just 5 or 10 millimeters less than systemic, you measure the PA pressure, the gradient you get across by subtracting this RV pressure minus PA pressure is equal to the gradient you got across the through the transesophageal echo.
Okay. Thank you so much.
And
I would think that echo gradients will be better because if the alignment is correct,
yes,
echo gradient will be better because there is no complexity or artifacts or technical errors of measurement when we put the needle size and depth. All those things will may influence the reading. So if it is echocardiography, there is only one beam. As long as it is parallel, I think it should give a fairly accurate
measurement.
Yeah.
And regarding additional VSD, the preoperative additional VSD is only made out easily by making out echo dropout in the interventricular septum, because the RV pressure, the moment contraction starts, reaches the systemic pressure. So it prevents any flow across the smaller VSDs. But in the post-op also, while coming off, if the RV pressure is almost like 10 difference or less than 10 to 15 millimeters less than systemic pressure, then we hardly see the shunt across the additional muscular VSDs, which even as you said, madam, the QPQS calculation is important. Surgeons would prefer to do a step up, RA to PA step up. But in tetralogy, many a times we have found that the even if it is around 3 millimeters, we might not get any step up. Step up will be significantly seen only if we have an VSD which is, as you said, greater than 5 millimeters. 5 millimeters VSD.
Yeah.
And in the transgastric approach, a very beautiful demonstration of the leak across the patch between the tricuspid valve and the patch can be demonstrated in the transgastric view, post-operative VSD. And the surgeon then immediately will confess that, yes, that was the bundle area which I did not take sutures nearby or close. So if it is little larger in that place, might be the surgeon has to go back and take some stitches, extra stitches to prevent that VSD. VSD is very well seen in the transgastric with the tricuspid valve in short axis and aortic valve with this VSD's patch lying down between the septal tricuspid valve and the aortic valve.
Yeah. Thank you so much.
Thank you, Keshav, for the comments. Well, we'll. I mean, the point is well taken.
One more last comment. RA, LA and LV are small in most of the cyanotic heart disease except truncus arteriosus.
Yes.
Because in TAPVC, tetralogy, and if there is a intact ventricular septum with TGA and the tricuspid atresia without pulmonary flow, all these have got smaller RA, LA and LV. So as you said, madam, if what we do is we put a LA line if we are doing in a infant like less than 6 months or 7 months to monitor the filling of the patient. So many a times we have found that pressure is low, volume is given, and patient suddenly you have a arrest in the following half an hour to 1 hour. So because the LA-LV is small, probably monitoring the LA pressure would be more a guide to systemic volume or inotrope in the tetralogy done at a very early age.
It's very correct.
Thank you, Keshav. There is one comment that absolutely wonderful session, and you are an excellent teacher. Thank you for that. Rupa, this comment is for you. And what is the difference between dysplastic and hypoplastic pulmonary valve? Dysplastic and hypoplastic pulmonary valve. Is there any difference?
Hypoplastic means it's just underdeveloped. Dysplastic, in the case of dysplastic, there may be pulmonary stenosis, there may be PR. I mean, it is just abnormal valve.
Sure.
Like an eaten up, yes. We see it sometimes like in infective endocarditis or somewhere like the valve is calcified. It is it's
abnormal. It is abnormal. It is abnormal. Yeah. Do you use 3D RV strain now to see whether RV function is better?
Only if there is a study going on. For routine clinical use, we do not use 3D at all.
Advantage of epicardial echo versus TE in post-repair assessment of TOF. What additional information do you get? What is the advantage of epicardial versus TE?
It is complementary. Epicardial echo is complementary. And as I said before, the surgeon, he feels that he's also doing something. So, and when he sees that it correlates with our measurement, then both teams are very happy. Yes. And we also get a confirmation.
Right. Which inotrope is more effective in meaning adrenaline or milrinone? Or you would like to add norepinephrine, dobutamine, norepinephrine? What combination do you use? Which inotrope do you use and why? What is the reason?
Usually the usual masala is milrinone.
Right. Do you have to address branch pulmonary vessel by cardiologists later on, like after 1 year?
I really don't know about the follow-up.
The branch pulmonary vessel stenosis, did you have any occasion where it was dilated later?
See, many times this branch pulmonary arteries, if the RV pressure remains high in the post-bypass period, the surgeon, surgeon tries to look at it. Visually, yes. He tries to look at it because LPA side, it is very difficult for us to see.
Yes.
Sir, one last comment about your if it is not getting long.
No.
Yes, sir. We did try in some cases after the surgeon returned back from US, wanted milrinone. Unless adrenaline, what happens? It acts both as a inotrope, and if you use it little higher concentrate, like higher amount, it uses vasoconstriction also. Yes. These tetralogies, especially little bit grown-up children, there is severe vasodilatation secondary to hypoxia everywhere. Yes. We add another vasodilator stronger as milrinone, then we find that how much ever volume you give, the patient doesn't get filled up and the systemic pressure doesn't come up. Many a times it has so happened that after those, for those surgeons, we had to start milrinone, then stop that midway after 10 or 15 minutes and start adrenaline or a vasoconstrictor like noradrenaline or vasopressin, as some of them use. I am very much wary about using norad or vasopressin because in the postoperative period in the ITU, whenever the pressure drops, people don't look at the cause for the pressure drop. The volume of noradrenaline or vasopressin going keeps on increasing. This has a very deleterious effect on the systemic perfusion, and we may land up with a lot of troubles. So unless it is indicated and they themselves feel, as I said in my previous talks or comments I have told, the dose of noradrenaline or vasopressin has to be sealed at certain level that you don't increase it beyond that. Anything else, you have to do manipulation with your milrinone, adrenaline, dobutamine, or other calcium, and not increase the dose of noradrenaline or vasopressin.
Okay, can I say that these patients who were hypoxic before bypass become oxygen tension increases and the vessels become very happy and they're relaxed and they're vasodilated, and that's why you need to have an idea that vasodilatation is occurring.
Yes, sir.
This is just an odd comment. But the next question is, do you
Even,
stop inotrope if gradient is high?
Yes, sir.
Stop inotropes when gradient is high. Okay. Any differentiation between Gorbode effect? What is the differentiation between Gorbode effect? What is Gorbode effect and what is the differentiation? Rupa, can you take up that question?
No, sir.
Keshav?
It's like the gradient across RVOT, you may find it across the LVOT, you may get a higher gradient if there is, if the patch is very much bulging into the LV side.
Right. And the last question of the day is it the mean or peak gradient which we give importance to? And what is the criteria for rootability of VSD? Do you take the mean gradient or peak gradient?
Peak gradient.
Who would like to take the peak gradient? Criteria for rootability of VSD?
The VSD, and here in tetralogy, it's not that much of an issue. Only thing is, if the overriding is more than 75%, etc., then there is chance that the LVOT will be little smaller when compared to 50% override as in classical tetralogy of Fallow. The rootability question occurs when you are doing a DORV VSD with some PS as a intracardiac correction rather than in a where you need a switch to be done. So in these cases, you need to see the VSD and the aortic valve where the PA is posterior and aorta is anterior. You have to see the aortic valve in the same view, and you will be able to see a path. That path should be equal to the aortic valve size. Otherwise, the root LVOTO is a left ventricular outflow tract obstruction can be seen in the postoperative period after the VSD patch is put. And one more thing which cardiologists do is they measure the distance between the if I'm one of the tricuspid valve and or one of the valves they measure, and they say probably this will be obstructed with distance from the aortic valve. If this will be obstructed, tricuspid valve to aortic valve, I suppose.
Yes.
I'm not very sure. They measure that and they say if it is smaller, then there is chances that there will be left ventricular outflow tract obstruction in the post-correction period.
Yeah, three things are measured: the size of the VSD, the size of the LVOT, and the distance of the tricuspid valve from the aortic valve.
Yeah.
And if the VSD size is, if the surgeon thinks it's small compared to the LV outflow tract, sometimes they enlarge the size of the VSD.
Okay. This is the other question is already answered here. Post correction after RVOT resection, transgastric Outflow view is better, and also in tubes it is the peak gradients, and in valve it is mean gradient. So that question is also answered here. So you go for peak gradients if it's a tube, and if it's a valve you go for mean gradients. And I think I think I should close the session now. We had a very nice session with a lot of input from the other faculty members, Keshav Murthy and others who participated. And I would like to thank Rupa Shreedhar once again for that excellent disposition or deliberation on tetralogy Fallow. Almost all aspects of tetralogy were covered within the given time. And I would like to thank the Forum of Cardiac Anesthesiologists for this platform. And please join us tomorrow for cardiac anesthesia critical care session. And I think we were going to deal with COVID infection in cardiac patients. And thank you so much. See you tomorrow.
Thank you, sir. Thank you,
Thank
madam.
you.
Very nice and beautiful presentation. Thank you.
Thank you very much. Thank you.
Thank you, ma'am. If I have a presentation, as sir told that tomorrow we'll be meeting for the FCA classes. Thank you for all the attendees. We'll meet tomorrow. Updated schedule will be sent it via the WhatsApp and the individual email IDs and the WhatsApp groups. Thank you all. Happy Sunday. Thank you.
Okay. Okay.